Good morning, everyone. Welcome you all in Pedia Academy by Dr. Pankaj. Myself, Dr. Pankaj, I'm pediatrician by profession, teacher by passion. We are discussing or continuing our series of INISS Neonatology Fast Track Revision series. So, today's topic is fetal and perinatal care of newborn, which is important for as a pediatrician exam point of view. Hope you liked all this video of these neonatology series. Please do share, like, and subscribe. So, without further delay, we'll start our discussion of fetal and parental care in like visits, all that. So, antenatal visits in ANC, our first topic is this. Okay, so this is actually somewhat controversial. WHO says generally 12 weeks, 20 weeks, 26 week, 30, 34, 36, and 40. These visits are must. Okay. Actually, visits will depend on obstetrician gynecologist preference of risk factor, but generally WHO recommendation is generally asked 12 week, 20 week, 26 week, 30, 34, 36, 40 weeks. NICE guideline says in this condition, a nulliparous woman should come for 10 visits and parous woman should come for 7 visits. So these are antenatal visits in ANC rough guidelines. Okay, what are the indications of delivery? This is important. Okay, basically, indication of delivery means any gestational age, presence of maternal indications means any gestational age, maternal indications are there like severe preeclampsia, HELP syndrome, other conditions which require immediate termination of pregnancy is indication of delivery. Spontaneous, repeated, unprovoked FHR deceleration. If your fetus FHR is going down, you have to terminate the pregnancy. Okay, abnormal biophysical profile score 4 or less. We'll discuss this biophysical profile score BPP along with modified BPP some time later. But if this score is less than 4, you have to terminate the pregnancy. Abnormal ductus venous waveform. Okay, just remember, we are not discussing umbilical artery or umbilical vein here. Just pay attention, it is abnormal ductus venous waveform. We'll discuss this later also. Okay, STV, so this is actually important thing. This is the parameter. Just remember, STV, if it is less than 4.5 after 34 week, generally this is most common condition we encounter in our perinatology consultations. If STV is less than 4.5 after 34 week, you have to terminate the pregnancy. Okay, this is very important and you have to remember this because this is PYQ also. Reverse and diastolic flow, it should be reverse in umbilical artery beyond 30 week. If your newborn is at beyond 30 week, 31, 32, 34, and you found it is a reverse and diastolic flow, just terminate the pregnancy. But if and your actually absent and diastolic flow is seen in umbilical artery 32 to 34 weeks. Okay, in this condition you have to terminate the pregnancy. So these two are important: reverse and diastolic flow beyond 30 week, terminate. Okay, and and absent and diastolic flow in umbilical artery 32 to 34 week, terminate. Okay, between 36 and 37 and between 38 to 39, two things you have to remember. Okay, so you have to deliver if your uterine artery pi is more than 95th centile, or your abdominal circumference or effective fetal weight is less than 3rd centile, and between 38 to 39 deliver if your cerebral blood flow is redistributed. Basically, I'm using these terminology as like UAPI, ACEFW, STV, biophysical profile score. You have to, we will discuss them in brief, but just remember these are the indication of delivery. Okay, in this you have to remember, just revise with me, any maternal condition, any FHR if going down, you have to deliver. Biophysical profile score if 4 or less, abnormal ductus venous waveform you have to deliver, STV is less than 4.5 after 34 week, and reverse and diastolic flow after 30 week of gestation, absent and diastolic flow after 32 to 34 week. An indication of delivery between 36 to 37 week is if your uterine artery PI is more than 95th centile or your abdominal circumference, and if upon effective fetal weight is less than third centile, deliver at 36 to 37 and 38 to 39 if cerebral blood flow redistribution is seen. This is actually quality care. We have to follow every obstetrician or gynecology should follow these indication of delivery for fetal or neonatal well-being. Okay. What are the indication of elective cesarean section? You have to do cesarean section. Okay, you found abnormal CTG STV. This is elective cesarean section. Ductus venosus Doppler alteration. Yes. Absence or reverse and diastolic flow, altered BPP and maternal indication. So we have understood this indication of delivery, indication of elective cesarean section. These are ultra important. Just pause this video here and revise them. I'll discuss, explain these actual terminology later. Okay, so what are the risk factor of GDM needing glucose tolerance test at first visit? Your a mother came in gynecologist OPD and gestational diabetes mellitus is suspected. Okay, so you will do GTT at first visit if her BMI is more than 30. Okay, previous macrosomic neonate weighting more than 4.5 kg or more, previous gestational diabetes mellitus, history of diabetes in family, history of polycystic ovarian syndrome, this was PYQ. Any history of PCOD, you have to check for GTT. Okay, planning delivery and other management, this is important. Okay, one more condition in antenatal period, it is most commonly found is hypertension in pregnancy, eclampsia and preeclampsia. In this condition, sometime early delivery is indicated. So, in which condition? Uncontrolled blood pressure despite 3 or more antihypertensive. You have to deliver before term. Oxygen saturation is less than 90. Second, prolonged worsening of liver and kidney function. Presence of neurological features. Placental abruption, reverse and diastolic flow in umbilical artery and non-assuring CTG. So these are the indication of clinical scenario can be made and question can be asked. What are the indication of preterm delivery in hypertensive female? Okay. Coming forward to our important topic, antenatal corticosteroid for preterm birth. So generally, as we know, we'll go actually step by step. This is important topic, so we'll spend some time here. Dexamethasone and betamethasone are two drugs which are used. Okay, so what happened? Dexamethasone is easily available, so this is drug of choice in our country. I'm saying this is drug of choice in India. Okay, so what is the dosing of dexamethasone? It is actually 6 milligram every 12 hourly. Total 4 doses and 24 milligram. You have to remember every bit of it means 6, 6, 6, 6. It is actually 12 hourly, 4 doses, total 24 doses. It is drug of choice in India. Betamethasone, it is ideal and it is drug of choice in other countries. What this betamethasone content, this is important. Betamethasone acetate, which is long acting, just remember this is long acting, this was PYQ. Betamethasone phosphate, this is fast acting. Ideally 1:1 mixture of these long acting and short acting betamethasone should be there. This is ideal preparation. But in India, only this betamethasone phosphate is available. Okay, someone says we have betamethasone, to ask them, do you have betamethasone combination or this phosphate? So in India, this is beta methazone phosphate is available, which is actually not a combination, so not ideal. So still you have to remember the dose is 12 milligram every 24 hourly, two doses, total 24 mg. Okay, just you saw the total dose is 24, be it dexamethasone or betamethasone. Okay, just pause this video and revise this dosing schedule again, because this is this was many times asked as dosing schedule. Okay, if you are thorough with dosing schedule and drug of choice. Okay, we'll go forward to some important points in this antenatal corticosteroids. They say even single dose is sufficient, means your mother came in emergency and delivery is due in next 12 hours and you just gave one dose. Single dose is also good because it is having 60 to 70% work for of it, like reduction of many things. Multiple pregnancy, this can be asked as a statement based or scenario based question. Twin pregnancy, will you give 24, 24, 48 milligram of dexamethasone? No, we will give only 24 milligram dexamethasone. Mother is diabetic on diabetes mellitus DM. So should we give less doses of steroid because sugar will shoot up? No, my dear friend, your dose of dexamethasone will remain same, but you have to monitor blood sugar level and use insulin if required in diabetic mothers. Okay, mother is already on oral steroids. Should we give more steroid? Which as HP axis is depressed or not? No, my dear friend, we will not care of HP axis as of now. We have to give same doses. So these four terminology: single dose effective, multiple pregnancy, mother diabetes, and mother on oral steroid, same dose is given. Okay, what are the contraindication? Maternal chorioamnitis is contraindication. What is not contraindication for antenatal corticosteroid is maternal diabetes mellitus. Just we discussed preeclampsia and hypertension. So we have to remember what are the indication, what are the contraindication. Okay. Repeat course of dexamethasone or antenatal corticosteroid. This is very controversial topic. Just remember this thing. Government of India and RCOG. Okay, Government of India and RCOG just don't recommend repeat doses, but we can, in practical case scenario, generally followed in many centers, we can give repeat course if your pregnancy is still less than 35 weeks, 36 plus 6, 34 plus 6. Okay, still it is having preterm risk labor within 7 days and prior dose is given more than 14 days ago. Some correction is there is repeat dose can be given within 7 days also. So in a nutshell, we can repeat this if required. Okay, to actually clear confusion, clear air on this protocols, I have compiled these all protocols in one slide. Just pay your attention. It is giving it has a very important implication in giving drugs to or antenatal steroids to mother, because ultimately we have to decide. Okay, these are three guidelines: RCOG 2021, ACOG 2017, and WHO 2022. Okay, so RCOG says just see single course is required. Single course is required. This course should be given in 24 to 36 week. Okay, if risk of preterm labor is there, generally it is given up to 35 week. All women of preterm birth risk. Okay, so RCOG says कि we are giving up to 35 week, but if risk is more, you can give up to 36 week. This is RCOG say, and they advocate only single course. What ACOG 17 guidelines said, 24 to 34 week, which are at risk of preterm delivery within 7 days. Okay, so they have actually gave criteria in two ranges: 24 to 34 week, which was similar to RCOG, and they gave 34 to 37. with preterm risk of 7 days we can give. So this is actually extra. Our ACOG guidelines are giving saying that 34 to 37 we can also give, and ACOG guidelines are in favor of repeat course. This is important. Okay, favor of repeat course ideal within 14 days. Earliest repeat course can be given within 7 days. You have to remember. WHO guidelines says that is given in 2022. The range is same 24 to 34 week plus the risk of preterm delivery within 7 days. No evidence of maternal infection. Adequate care is available. 34 to 37 they don't advocate a repeat course in WHO. Just remember they say within 7 days. So repeat course RCOG and Government of India are not in favor, but ACOG and WHO says repeat course can be given. ACOG says in 14 days and WHO says in 7 days. Okay, all range of this actually giving steroid is 24 to 34 week standard. RCOG says you can give up to 35 week. ACOG says you can give up to 37 week, and WHO says you can give up to 34 week. Okay, at the end it will depend on consulting obstetrician and pediatrician perinatologist to decide when to give antenatal corticosteroid by analyzing all factors. Okay, so this was about antenatal corticosteroids. We'll discuss some important thing which is fetal movement counting, which is also important. Just remember, fetal sleep cycle is 20 to 40 minutes. Practically, it never exceeds beyond 90 minutes. This is important. This can be asked in exam. What is the fetal sleep cycle? It is 20 to 40 minutes. Practically, the fetus never sleep beyond 90 minutes. So, ACOG recommends less than 10 movements within 2 hours are abnormal. So, less than 10 movements within 2 hours are abnormal. Two important methods are used. First is Cardiff method and second is Sandowski method. In Cardiff method, what they do, they count 10 movements in 12 hours, which is important. And in Sandowski method, they count in 30 minutes to 1 hour, they count movements. So this fetal movement counting is important. Fetal sleep cycle and Cardiff method, Sandowski method, you have to remember this. Okay, what happen if your fetus is in stress? Okay, first what he or she will do, decrease fetal growth rate is primary adaptive response. In secondary adaptive response, what happen? Decrease fetal movement and decrease FHR will be seen, circulatory redistribution will be seen, polycythemia will be seen. Okay, progressive decompression, what will be seen? Absent diastolic flow, low biophysical profile, and persistent late deceleration. And the end result is death if no intervention is there. Okay, going forward to biophysical profile score, it is actually you have to remember this. Biophysical profile score is having 3, 4, 1, 2, 3, 4, 5 things. What are the 5 things? Fetal breathing movements, fetal tone, amniotic fluid, non-stress test. The scoring system is normal score is 2, abnormal is 0. You have to remember this. This is actually normal score 2, abnormal score is 0. So fetal breathing movements, fetal tone, amniotic fluid and non-stress test. You have to remember them all. Okay. I'm not overwhelming you guys with this BPP. You have to remember this. What is the normal thing? Fetal breathing, if you see one episode of at least 30 seconds in 30 minutes, means fetal is breathing. If in 30 minutes, if it is breathing for 30 seconds, it is normal. Fetal movements, 3 discrete body limb movements in 30 minutes. So breathing is 1 and body movements, fetal movement should be 3 in 30 minutes. Fetal tone, 1 episode of active extension return to flexion. Amniotic fluid, at least 1 pocket measuring at least 2 cm in 2 perpendicular plane. So this is important. Non-reactive NST should be reactive. What is NST? We'll discuss. According to this, 0 and 2 score are given. Just remember one thing. Modified BPP is also used, which use NST plus AFI. Okay, NST and amniotic fluid index. So this was PYQ also. NST and AFI was used. Okay, so how you will interpret this? Just this table, and this is also important. So just remember, if your BPP score is 8 by 10, just exclude this amniotic fluid. Okay, 8 by 10 plus your normal amniotic fluid is there, it is normal. But if your score is 6 by 10 plus your amniotic fluid is normal, it is equivocal. If your score is 6 by 10 plus oligohydramnios, it is abnormal. And if your score is 0 to 4 by 10, termination of pregnancy. As we discussed earlier also, termination of pregnancy criteria, one of the criteria is your biophysical profile score is less than 4. Okay, so you have to be well versed with biophysical profile scoring system. What is modified BPP? What are the component of BPP like fetal breathing, fetal movement, fetal tone, amniotic fluid, and non-stress test? What normally is seen like one moment of fetal breathing, three moment of fetal movement, one episode of active flex extension, amniotic fluid, and non-stress test. You have to remember this. So non-stress test, as we know, this non-stress test is what happened in this two fetal heart acceleration exceeding 15 beats per minute and at least for 15 seconds during monitoring period. Okay, so basically what they say, the fetal heart rate, two fetal heart rate acceleration are seen, okay, exceeding 12 beats per minute and taking at least 15 seconds. Okay, so this is normal NST, one of the component of this modified biophysical profile and also biophysical profile per se. Okay, so Doppler velocimetry interpretation, this is not tough, just trust me, just be with me. What we'll do by Doppler ultrasound, we will see some some alteration velocimetry in umbilical artery. Okay, understood? In middle cerebral artery, in ductus venosus, in aortic isthmus, and maternal uterine artery. Just remember these 3-4 arteries we will use and we will discuss significance of them. Okay, so first thing first, if your umbilical artery, if your umbilical artery is showing placental resistance in fetal cardiac afterload, this is important. Umbilical artery is, if you found increased resistance in umbilical artery, the risk of hypoxia and absence of reverse diastolic flow indicates of risk of acidosis. So umbilical artery we have discussed earlier also, if found absent or decreased flow, you have to terminate pregnancy. Middle cerebral artery, we are talking about brain, fetal middle cerebral artery. If low pulsatility index PI is found, it indicates brain sparing effect and possible fetal hypoxia. Ductal venosus, this is actually a very serious thing. If you found absence of reverse flow, this associated risk factor of fetal mortality and morbidity, this is serious. So this is very important. Aortic isthmus neurological injuries are more. Maternal uterine artery, it's suggestive of resistance from maternal side. Okay, so it's suggestive of poor uteroplacental perfusion. Okay, just pause this slide and this is very important. You have to remember all these because umbilical artery, middle cerebral artery, ductus venosus and maternal uterine artery. Okay, just be with me. Uterine artery. In this condition, what happened? This is uterine artery and this is your flow. Okay, this is your flow. This is suggestive of uteroplacental insufficiency. PI more than 95th centile. Okay, umbilical artery. This is we see uterine artery from mother side uteroplacental insufficiency is seen, but what is more important is from fetal side, that is umbilical artery. This is actually absent and diastolic flow. You are able to see absent and diastolic flow. In this condition, we terminate the pregnancy at 34 weeks of gestation around. And this is a reverse and diastolic flow. In this condition, we terminate pregnancy after 30 weeks of gestation. That's why I'm discussing more time to explaining them, because this is practical point of view also. You found this and diastolic flow terminate pregnancy at 30 week, and this terminate pregnancy at this you have to terminate in 30 weeks and in 34 weeks termination. Okay, middle cerebral artery MCA. This is suggestive PI less than 5th centile. This is suggestive of cerebral circulation and suggestive hypoxia. Okay, next, ductus venosus. I told you ductus venosus, if this is absent A wave is not seen in reverse A wave. In this condition, ductus venosus is very important. It is late change. It is very dangerous. You have to terminate pregnancy at all. Cerebroplacental ratio. This is a ratio of MCA-PI to uterine artery PI. It is surrogate marker of brain sparing effect. This actually sentence or this was asked in AIIMS exam. So this is a PYQ question. You have to remember what is cerebroplacental ratio. Okay. Now I'll discuss IGR. Okay, fetal growth restriction. As you know, early onset FGR are rare, but late onset fetal growth restriction is actually prevalence is high. What is the pathogenesis behind this? Trophoblastic invasion is impaired in early onset FGR and reduced villus surface area, and defective villus maturation is seen in late onset FGR. Placental disease is severe in early onset and hypoxia is marked. So Doppler changes, just see with me. First thing, uterine artery PI will deteriorate, then cerebroplacental circulation will go, uterine umbilical artery PI, MCA PI. After that, uterine artery absent and diastolic flow. After that, uterine artery reverse and diastolic flow. DV absent A and uh, DV absent A and DV reversal. Just you saw ductus venosus reversal is actually last thing or near deterioration thing. So this is very deteriorating thing after CTG deceleration and poor growth. In late onset FGR, generally we don't see changes in DV. So DV, ductus venosus changes are seen in early FGR. So this is also similar to that. Okay, as we discussed also, high mortality and high morbidity are seen in early onset fetal growth restriction. So we understood till now early onset fetal growth restriction is very severe, associated with ductus venosus abnormalities and impaired trophoblastic invasion and reduced villus surface area are most commonly implemented. Okay. So, definition of fetal growth restriction, what we'll discuss. Just see, 32 week is cut off. You have to remember this 32 week. So, early FGR, it is seen in less than 32 week, and late FGR, as we discussed earlier also, it is seen after 32 week. What is the definition? You have to remember this definition. This is very important. If your abdominal circumference upon effective fetal birth weight is less than third centile, or your uterine artery absent and diastolic flow is there, anything should be there, or your AC EFW is less than 10th centile along with your uterine artery PI more than 95th centile and uterine artery PI is more than umbilical artery PI is more than 95th centile. This definition is of early onset FGR. Similarly, late onset FGR is if your AC EFW is less than 3rd centile or at least 2 out of 3 is there. That is AC upon EFW is less than 10 centile, AC EFW crossing centile more than 2 quartiles and your cerebroplacental circulation ratio is less than 5th centile or UAPI is 95th centile. So this is very important. Okay, you have to remember this. Basically, just pause this video and just see IUGR, fetal growth restriction. What are the definition? You have to remember these and what are the basically a difference between FGR and this is actually early and late FGR. Okay, now we'll discuss this protocol, important protocol of fetal growth restriction. Why we discuss this fetal growth restriction in detail? Because delivery and other management will depend on this. Okay, if your fetus is small for gestation age, so what is the definition of small for gestation age at USG parameters, Doppler criteria? If your effective fetal weight is less than 10th centile, what you will do? Timing of delivery is normal at 40 week of gestation by normal labor. Okay, but FGR is classified as 1, stage 2, stage 3, stage 4. So stage 1 FGR, stage 2 FGR, stage 3 FGR, stage 4 FGR. Just remember mild placental insufficiency, severe placental insufficiency, low onset signs of fetal acidosis and high suspicion of fetal acidosis. So first is mild placental insufficiency, second is severe placental insufficiency, third is low suspicion of fetal acidosis and fourth is high suspicion of fetal acidosis. Okay, just remember with me in stage 2 uterine artery absent diastolic flow is given, it is generally seen in stage 2. If uterine artery reverse and diastolic flow is given, it is considered at stage 3. And if your ductus venous reversal are seen, it is seen at stage 4. Other thing like if your uterine artery PI is more than 95th centile, MCA is less than 5th, uterine artery PI is more than 95th, and CPR is less than 5th centile. These are stage 1 criteria. We have discussed them earlier also. Just pause this video and try to recollect. We have discussed earlier if your uterine artery and diastolic flow is there. Okay, you have to terminate this pregnancy at 34 week of gestation because this is criteria of stage 2 severe placental insufficiency. But if your reversal and diastolic flow is there, you have to terminate the pregnancy at 30 week. Okay, and if your DV reversal deceleration seen, you have to remember, you have to terminate this pregnancy because this will create problem at 26 of week of gestation. Just remember, any umbilical artery or DV abnormalities, the mode of delivery should be cesarean section. You have to remember this. And other stage 1 FGR, okay, in this condition you have to deliver the patient is 37 week of gestation by induction. Okay, so it might look overwhelming. What you have to do, just take a deep breath. This is not that difficult. Just pause this video and revise this video again. Okay, play this video again and you will actually understand this, what is the crux I'm trying to tell you. Okay, so yeah, monitoring, you have to monitor. So this is actually we'll skip this slide. Okay, so this was just your fetal monitoring. Now we are into intrapartum monitoring. So ACOG says your intrapartum monitoring having 3 stages: category 1, category 2, category 3. Okay, so category 1 is normal. If your fetal heart rate is Baseline rate is 110 by 160. It is okay. Moderate baseline FHR variability. What is normal variability? Is 6 to 25 beats per minute between contraction. No late and variable deceleration. Early deceleration may be present. Early deceleration may be present. Acceleration may be present or absent. What you have to do, you have to remember all these. Just revise with me. Baseline heart rate is 110 to 160. Moderate baseline FHR variability is 6 to 25 bpm between contractions. No late or variable deceleration. Early deceleration may present or absent, and acceleration may present or absent. So this is important. In categories third, any one or two if present, that is absent baseline FHR variability, recurrent late deceleration, recurrent variable deceleration, bradycardia and sinusoidal pattern, it is called as category third, and category 2 will be basically in between category 1 and third. So you have to remember these category. Now we'll discuss category 1 tracing. Okay, as we discussed, in this condition, your fetal heart rate is 110 by fetal heart rate is 110 by 160. Okay, your absence of late and variable FHR deceleration, you will not find that. Moderate FHR variability 6 to 25. Early deceleration, acceleration may be present or absent. So this is category 1 tracing. Going down, this is early deceleration. You find in this condition deceleration is seen. Okay, generally this deceleration is coincide with peak of contraction. You find this is actually coinciding with peak of contraction. This is definition of early deceleration, and it occurred due to head compression. So this was PIQ. This actually CTG can be asked. It is early deceleration. Generally peak coincide with this uterine contraction. It is seen in head compression. This is fetal tachycardia. Okay, not so important. Important is this is actually baseline variability I'm trying to discuss. This is absent baseline variability. This is minimal baseline variability less than 5 beats per minute. This is moderate baseline variability 6 to 25 beats per minute. Okay, going forward to late decelerations. Okay, so this is late deceleration. In this, the gradual decrease in FHR by at least 15 beats per minute below the baseline lasting for 15 seconds. It comes after onset of contraction and after the contraction has paused. Okay, so just see this deacceleration. It start after onset of contraction and ends after the contraction has passed. Late deceleration is suggestive of uteroplacental insufficiency. This was P by Q. Okay, this is variable deceleration. Okay, this is seen in cord compression. So this is variable, no pre and post criteria is seen. So this is seen in variable cord compression. Fetal blood sampling, if you do, generally pH is more than 7.25, lactate is 4.2, it will be called as normal. Okay, and this result less than 7.20 or more than 4.8 is abnormal. Okay, so you have to remember this fetal pH monitoring criteria because this can be asked in exam. Okay, now we're done with fetal monitoring and intrapartum monitoring. Perinatal monitoring, actually, you have to delay cord clamping for some point we will discuss. Delay cord clamping for 60 seconds and monitor neonate breathing and color every 15 minutes. This is skin to skin contact just after birth. Some definition of term pregnancy is 37 to 42 weeks. Early term is 37 to 30, actually 9. 41 to 43 is late term pregnancy. Preterm pregnancy late is 34 to 36 plus 6. These are some terminology you have to just go through once. Okay. So this is classical presentation of heat loss by conduction, convection, evaporation and radiation. Just go through them once. This is actually easy. Oh, I want to actually draw your attention here. This is body surface area. So, relative skin surface area in adult and LBW. In adult skin surface area, I'm not talking about body surface area. This is skin surface area. It is 250 centimeters square per kg. But just see what happened in 500-gram infant. It is 1400. This can be asked in exam. 1400 centimeters square per kg. That's why more heat losses occur. Okay, so what is the normal temperature range? Your normal auxiliary temperature 36.5 to 37.5. Mild hypothermia or cold stress is seen in 36 to 36.4. Moderate hypothermia is 32 to 35.9. Severe less than 32, and hyperthermia 37.5. You can remember rough values at less than 32, 32 to 36 and 36 to 35. Severe, moderate and mild hypothermia. Okay, these are thermoneutral zones. You have to remember these. Okay, so just go through this slide once. These are thermoneutral zone, like less than 1500, 35 degree at 1 or 10 days old is thermoneutral zone. Okay, so if your neonate is hypothermia, you found a neonate in hypothermia. If your temperature is 36 to 34, it is in cold stress. Just warm the baby and breastfeeding is required. If your neonate is like moderate hypothermia, 32 to 35.9, provide extra heat, STS. But if your neonate is in severe hypothermia less than 32 week, this was asked in exam, you have to rewarm. In rapid rewarming is done until 34 degree, it was P by Q, and again slow rewarming up to 36.5 degree. Just don't give feed at start IV fluid. This was also P by Q. Okay, so these were two P by Q. 34 degree start, don't give initial feed, start intra IVF. Okay, then delivery room temperature and all these things. Okay, so delivery room temperature should be at least 26 degrees. uh, Ideal temperature should be like 26 to 28, and cold clamping 30 minutes, 30 seconds to 1 minute. Less than 32-week baby, you have to actually do not dry the neonate, you have to actually use polythene bags. And yeah, avoid self-inflating bag in less than 32 week of gestation. These are some criterias. Target oxygen saturation. Okay, so that's how we have completed fetal and parental care. Hope you like this video. Okay, if you like this, do share, like and